we thought now was a good time to remind those of you who've been involved in REMAP CAP for a while about the trial. And also, I think looking at some names, I think we've got some new people attending, so that's great. First of all, I hope you all had a good summer and settling back in as the weather's starting to change, and we're getting a little bit into flu season. I don't know if it's really started, but we have had a few flu recruits these last few weeks, so maybe it is starting. So this is very timely, I think. Just to let you know that we will be recording the presentation, so that for those people who couldn't join us, they can see it. It will go on the website. We generally don't put the Q&A at the end, so do feel free to ask questions. Don't worry, you won't be on the recording, but maybe actually we might take some questions and always add them to an FAQ so people can still hear the answers. So we're going to concentrate on adults for today. There's a separate pediatric session on Thursday. So this is really focused around the adult aspects of the platform. So let's see if it's moving along. It worked with, oh, okay. So these are what we're going to talk about today and outline, and I think that maybe it's just easier to get straight on. So just to remind you that REMAP CAP is a global trial, and it has sponsors in different regions around the world. Obviously, we are in Europe, and our European sponsor is UMC Utrecht. The overall EU lead is Lenny Durdy, based in Utrecht, with Mark Bonton, and I lead the UK. But it's not just me, it's the whole team, and hopefully you've met many of the team. Certainly will have had emails from many of them, but you can see the whole team here. Many of them are on this call as well. So it's really coordinated by Imperial and ICNARC working together. And just to remind you, we're concentrating about the influenza part of REMAP CAP, which was funded by the NHR as the national platform a couple of years ago. You'll notice that the end date of the grant is currently next month, but we'll update you about that towards the end. And so again, just to remind you, this international adaptive platform trial for severely ill patients with community-acquired pneumonia was set up pre-COVID to be able to generate evidence outside of a pandemic that we could then adjust in a pandemic and find out the best treatments that reduce mortality, ICU use, and morbidity in these severely ill patients. And the idea of this adaptive platform is that there is this sort of overall outer shell, which is the overall platform. It includes patients, obviously, with a community-acquired pneumonia. And then if you meet the criteria for the different platform, the way we have it set up with different domains, which test different treatments, we can almost do multiple trials within the overall platform at the same time, getting many efficiencies in terms of recruitment to multiple domains and bringing in new treatments over time. And so starting pre-COVID, just to remind you a bit of background, we started with community-acquired pneumonia, generally bacterial. And then when COVID came along, we had to make adjustments. And so we actually talked about within that overall platform that there are these various different disease strata, and we analyzed patients according to these disease strata. So we added COVID-19 4.5 years ago. And that led us to publish results that you'll be familiar with on 14 different treatments over that period, some showing benefit, some showing no benefit, and even some showing harm. And just to remind you, one of the features about the trial is that it is a Bayesian adaptive trial. It means we have no fixed sample size. We keep on enrolling patients until we meet predefined thresholds to say something is either effective, ineffective, or maybe even harmful. So to illustrate how that works on this Bayesian model, when we run the analysis at intervals, it updates the probability that a treatment may or may not be working. So if we took here an odds ratio of 1, we start with a prior, it's a weak prior, so centered around the 0.1. Maybe it works, maybe it doesn't, but very weak evidence. As we randomize patients to get more data, we update that probability threshold that the treatment may work. In this case, odds ratio above 1 is beneficial, we'll say. And you keep on enrolling patients, adding more data. And as you see here, as you learn this with this effective treatment, you'll get to a point where you get really strong evidence that a treatment may be working. And so we might say here with this hash lines, there's this, you can see 99% probability that the treatment is better than the control in this case, so with an odds ratio greater than 1. So that is how the trial works. We then, as I said, with the funding from 2 years ago from the NIHR, added the influenza stratum so that we would include patients with influenza. And when we did that as well as including adult patients, we also started including children. And we've divided them above and below 12. And what we do actually is we consider the adults and the teenagers, those above 12, we analyze them all together. In fact, the teenagers probably behave more like adults. So we still call them, we've got them in a separate group for logistic reasons, regulatory purposes, many that children get treated separately. But we analyze the adults and over 12s together, and the under 12s get analyzed separately. And we divide patients into different illness states. We call them severe and moderate states of illness. But essentially, the severe state is those who are critically ill. So they're receiving some form of respiratory or cardiovascular organ support in an ICU. Everybody else, including all the ward patients, are in the moderate state, not critically ill. And we use a Bayesian hierarchical model, which I won't go into the details now, but in other words, all of these patients contribute to the overall analytical model, but we can look at the patients in these different states and strata to understand where it does and doesn't work for each treatment. So within these different pathogen strata here for the influenza, what we have is then the treatments that we would consider. As I said, each one is almost like its own trial. So we have an antiviral domain, which, as well as testing against control, we're testing oseltamivir, baloxavir, and the combination of the two. We have a steroid domain, which is comparing dexamethasone versus no steroids. And in the ICU, from a study that we had going on before COVID, we're actually testing hydrocortisone as well, but that's only in the ICU patients. And then more recently, within the influenza stratum, we've added an immune modulation domain, which we'll go into more detail on this talk later, but looking at the effect of tocilizumab or baricitinib versus control. And so I know I went through it rather rapidly, but we just wanted to point out when we're talking about the terminology, influenza is not a domain, it's a stratum within REMAP CAP. So the reason we say that is that some people thought that it may be only one set of treatments available for influenza, particularly the antivirals. But hopefully it's sort of illustrated that within the stratum of influenza, there are actually 3 domains of interest: the antivirals, the steroids, and if they're critically ill, the immune modulation drugs. So that we're running those effectively sort of 3 types of trial in the influenza patients. Depending on their eligibility, patients with influenza may be randomized to 1, 2, or even 3 different treatments, one from each of those domains. So who is eligible for the study? Well, first of all, we've got who's eligible for the overall platform. And so now that we include adults and children, and that's for children, it's 28 days or older corrected gestational age, that they're in the hospital, anywhere in the ward or the ICU, And they're there because of acute illness due to the respiratory tract infection. So as you'll see, we're not recruiting patients who happen to just have a positive swab result, for instance. It is people who are acutely unwell because of their respiratory tract infection. We're only including patients within their first 2 weeks of the hospital admission. And if they're critically ill at the time of randomization, it has to be within the first 48 hours of their ICU admission. If again, we think our treatments are more effective if we treat people early. So we want to recognize them within their first 2 days of ICU admission. And otherwise, it's very pragmatic. The other exclusion criteria for the platform is if they are actively dying within the next 24 hours. It's unlikely we would be able to make any difference if they're that sick. Or alternative, if the patient's already got better and they're about to go home in the next day, again, we're not including them because the treatments are not likely to affect their outcome. And of course, patients can only be in the trial once in the follow-up period, so within the 90-day of recruitment, as that's part of our primary outcome. So a little bit about the different domains. So remember, each of the domains is a group of drugs that have a common mode of action. So we have in the influenza antiviral eligibility criteria is the patient must test positive for influenza infection. And that can be by any means. There's no specific, whether it be a rapid PCR test or any laboratory-based test, that's fine. So it just must be positive for influenza. And again, trying to treat people early. So we say if they're on the ward, in the moderate state, they must be within 96 hours, or if they're in the ICU, within 48 hours of ICU admission. We don't want to randomize patients who've already been treated with these drugs. So if they've had 2 doses of oseltamivir or 1 dose of baloxavir, baloxavir is not given as frequently, it has a long half-life. So we would say if either 2 doses of oseltamivir or 1 dose of baloxavir, they've already been treated for their antiviral. And so we're not randomizing them because we think that they've already had their treatment. Allergies is an exclusion to the specific intervention. And pregnancy is an exclusion for baloxavir only. So if you do have any pregnant patients, they can be randomized to oseltamivir or control. The system, our randomization system, will do that automatically for you. You would enter that the patient was pregnant, and it wouldn't allow baloxavir to be one of the randomization options. We have videos for each of the domains. For the sake of time, I'm not going to go through all of them now, but there's one here explaining a little bit more about the influenza antiviral from Srin Murthy, who's based in Canada. And you can see his video, just a few minutes long. It'll be available on the website. So we'll skip over that for now and go to the corticosteroid eligibility criteria. So for corticosteroids, we want just slightly sicker patients. They must be receiving oxygen to be eligible for this domain. As we saw in COVID, that steroids didn't seem to work and may have even been harmful for patients without an oxygen requirement. So we're not including them. So to be eligible for steroids, it's any form of supplemental oxygen that could include non-invasive ventilation and full ventilation, or just a simple nasal prongs. Anything counts. So that would be they're eligible. If they're in ICU, and it's ICU only, if they have to be recruited in the first 24 hours. Again, thinking that if they've got that sick, we want them within the first 24 hours of being critically ill. That time period doesn't apply on the ward. And obviously, if you're going to give them steroids for another reason already, or if they're already on the steroids and it's systemic steroids, not eye drops, not inhalers and so on, they can, but they shouldn't be randomized if they're getting systemic steroids. And similarly, we have another short video, this time from Derek Angus in Pittsburgh, explaining the corticosteroid domain. Again, I won't spend time on it now. Many of you will have seen it before, and it's available on our website. What I do want to spend more time about is talking about the immune modulation domain, because that's new, that opened up at just the very end of the season, flu season last year. And so many of you won't have recruited to it yet. So I thought it would worth highlighting who's eligible for this. So it is for influenza patients only. So they must test positive for influenza. And it's only available for the critically ill patients, so in that severe disease state, so in the ICU receiving some form of organ support. Patients who are excluded is patients who have immune suppression already, including neutropenia, if they have active TB or invasive fungal disease. So it's not previous TB, it's not just a suspicion of TB, it's if they actually have active TB and are being treated for it. And similarly, if they have invasive fungal disease. So you can still include a patient who might test positive on a swab, for instance, when they came into hospital or the ICU. If they're already receiving immune modulation, IL-6 receptor antagonist or JAK inhibitor, and so this would exclude COVID patients because, again, that should be part of their standard of care. If they're allergic to the interventions, and at the moment in the UK, pregnancy would exclude all patients from this domain. We are working with the MHRA to hopefully allow the potential to randomize to tocilizumab only as the treatment that could be used in pregnancy, but it's not open right now in the UK. So I'm going to let Tom Hills explain a little bit more and a little bit more detail about the immune modulation domain. There's a video for a few minutes here now.
Hi everyone, my name's Tom Hills. I'm an infectious diseases physician and clinical immunologist in Auckland, New Zealand. I'd like to talk to you about the influenza immune modulation domain, a new domain in REMAP CAP. And this domain is approved here in New Zealand, it's approved in the UK, and we're excited to see more and more regions coming on board. Here we're looking to build on knowledge from the pandemic and apply that to other viral infections and evaluate whether these therapies, tocilizumab and baricitinib, which are effective in severe COVID-19, are effective therapies in severe influenza. The reason we're interested in doing that is that there are similarities in terms of the immune response in patients with severe COVID-19 and severe influenza. Interleukin-6 is a critical cytokine in that host response to these severe viral infections, with IL-6 levels being highly elevated in both severe COVID-19 and severe influenza patients. High IL-6 concentration associated with disease severity, mortality, inversely associated with arterial oxygen levels in hospitalized influenza patients. It's not clear whether those high IL-6 levels are a marker of disease severity or a mediator, whether that IL-6 is involved in the pathophysiology of severe influenza infection. Because of the findings in severe COVID-19 patients, we're very interested in evaluating these immune modulatory therapies in severe influenza. So we propose evaluating no immune modulation versus tocilizumab versus baricitinib. Tocilizumab will be familiar to many of you as an intervention that was studied in the IM1 COVID-19 immune modulation domain, where many patients were recruited from the UK, and it was evaluated alongside a similar IL-6 receptor antagonist called sarilumab, and both were shown to be very effective treatments for severe COVID-19. Baricitinib is also now widely used as an approved treatment for patients with severe COVID-19. This is another medicine that we're repurposing from the outpatient clinical immunology rheumatology world, where it's used for autoimmune diseases and atopic diseases, and it inhibits the downstream signaling of cytokines like IL-6. It's also effective in severe COVID-19, as demonstrated here in a figure from the recovery trial. So our question is, does treatment with these immune modulators, tocilizumab or baricitinib, improve outcomes for critically ill patients with severe influenza? The inclusion criteria reflect the approved use of tocilizumab and baricitinib in severe COVID-19. So we're constraining this to patients who are at least 2 years old, are in the severe state of REMAP CAP, so critically ill receiving organ failure support. Influenza virus infection has been confirmed by microbiological testing, and influenza virus infection is the reason the patient's in the severe state, rather than they're in a critical care unit with trauma and happen to have influenza. We exclude patients who have SARS-CoV-2 infection because these agents will be standard of care for those patients. And then we have some other exclusions, again, based on the use of these drugs for COVID-19, such as significant immunosuppression, an invasive infection with something like a bacteria or fungus, or people have already received these drugs or a related drug. Importantly, if patients are pending the result of an influenza test, they can be enrolled, and then their treatment assignment can be revealed once those test results become available. We understand that some patients may be enrolled in the platform and receive treatment allocations in other domains where the influenza testing information is not required, and this domain is something that they can be enrolled in, and their treatment assignment can be revealed using a delayed reveal when the influenza test result becomes available. Dosing of tocilizumab is as given for patients with severe COVID-19, 8 milligrams per kilogram up to 800 milligrams for adults, and we're giving a single dose. A minority of COVID-19 patients in studies and in clinical care may receive a second dose, but we're evaluating a single dose here. Pediatric dosing is the same as adults for children who are at least 30 kilograms, but children who are less than 30 kilograms have a 12 mg per kg dose. And again, this is in keeping with the approved dosing for COVID-19. Baricitinib is an enteral medicine, and its dose depends on renal function. So there are some EGFR bands there, and this reflects the dosing used for COVID-19. And in children who are at least 9 years old, adult dosing is being evaluated, and in children who are less than 9 years, as with clinical use of baricitinib for COVID-19, we use a slightly lower dosing. The primary endpoint will be the same as for other domains in REMAP CAP as defined in the core protocol. Important secondary endpoints for this domain include positive blood culture results for bacteria or fungus that identified more than 48 hours following randomization. And pulmonary aspergillosis diagnosed more than 48 hours following randomization. There were not significant safety concerns in terms of secondary infections when these drugs were used for COVID-19, but influenza is different, and there may be higher rates of co-infection in patients at baseline, and we felt it was prudent to collect information on secondary infections using this definition of blood cultures and pulmonary aspergillosis as key clinically relevant infections, and we want to evaluate whether there is any increased risk with these agents, contributing more to the data on the safety of these drugs in critically ill patients with viral pneumonia. I'd like to thank you all for your time and for your interest in this domain, from down here in the bottom corner of this map to your team all clustered in the middle at all those sites in the United Kingdom. I'd like to thank you for all your work recruiting patients, and please reach out via the team in the UK if you have any questions. Thank you.
So hopefully that was useful to hear about the immune modulation domain. I'm sure there'll be some questions. So we'll have a pause in a moment where you can ask questions, either putting your hand up or in the chat. Just to show you where we are as far as recruitment. It's over 14,000 patients now have been randomized in the REMAP CAP global platform. Obviously, many of those, over 10,000 of those are COVID patients, but 6,000 in the UK. For specific influenza domains or treatments here, there's 426 influenza antiviral patients recruited around the world, just under half of those from the UK. The steroid number you'll see is a lot higher. That reflects the fact that many of these patients will be recruited prior to COVID even, and many of them have bacterial community-acquired pneumonia. The number with flu is just a few hundred at the moment, but hopefully we will accumulate more steroid patients for the influenza strata soon. And although we haven't recruited anybody in the UK yet with the influenza immune modulation, as I said, it only started in about March, April time of this year. Of course, down in New Zealand, where Tom is based, they've had it open for a few months now, and they recruited the first 3 patients down there into that domain. To get it, for those of you who are not open to the influenza stratum at the moment, you need amendments 37 to 40 all approved, and you need to select the choices of the interventions. Remember, not every site has to have every drug open for each of these domains. You select which ones you want to take part in. Hopefully you'll take part in all of them, but we realize there may be some reasons why that may not be possible. So the idea is we're modular, so hopefully all of the sites can take part in at least some part of the overall platform. Do need to make sure the relevant staff have done their training, and we do need those logs. The MHRA do like to see those. The drugs that are in common use, the oseltamivir, dexamethasone, and baricitinib, will all come from hospital stock. Roche have very kindly donated both baloxavir and tocilizumab to the trial free of charge. So we can supply those to you. And so as soon as your site is activated, if you fill in the order forms, we can make sure the drug gets to you. But if you have any questions over this, you can email the team on the usual email address. I see a hand up. I'll come to that in a moment. Because, yeah, I was just...
Thanks, yeah.
Yeah, okay. So just a reminder, in regards to matrons as professional legal representatives, during the Substantial Amendment 41, we put this through so that we can allow matrons to now act as pro-LARs. And that should help with issues where sites don't have enough doctors to be eligibility checkers for this. In terms of consent documents, we do have a slight change in our processes where we will be localizing PIS and consent form documents on behalf of sites. This is as per the sponsor request, and it is because we have various sections in the PIS that may require deletion or amending, depending on which interventions sites take part in, and just to avoid any sort of mistakes and things being made. So we would likely request logos and headers so that we can add those in, and any sort of local contact details, and then we'll make the adaptations required and send sites a PDF locked version of that. Translated PIS documents will be available following the next amendment, so those aren't available just yet. And here we've just got a consent animation for video consent, and then I can explain how we use that. I can't actually see. Oh, I think it started playing. Everyone hear that?
Yeah.
Research is how healthcare professionals find out the best way to treat illnesses or health conditions. Most hospitals and many healthcare professionals are involved with research. It's an everyday part of what we do. GPs, doctors, nurses, physiotherapists, pharmacists. Everyone wants to make the care better for people who need it. All research is looked at by an independent research ethics committee who check that it is okay for people to take part in. Taking part in research may or may not help the person taking part, but it will help healthcare professionals learn more about the best treatments of people who have the same illness or condition. We will only ask you if you would like to take part in research if your doctor says it is okay for you to take part. A research nurse will talk to you about the research and you can ask questions about it. If you say yes or no, it will not make a difference to the care you receive. You will still be looked after by your healthcare team. If you say yes, you will be asked to sign a form called a consent form to show that you want to take part in this research. Even after you've signed the consent form, you can still change your mind and say you no longer want to be part of this research. Sometimes people are too ill or not able to understand the research to say yes or no. Then someone close to them, a family member or friend, will be asked if they think that the person would like to take part in research. If there is no friend or family member able to talk with the research nurse, then an independent doctor who is not part of the research study is asked to say yes or no. As soon as the patient is well enough and is able to understand the research later on, they'll be asked if they want to stay in the research study, and they can say yes or no. This video is about a research trial called REMAP CAP. This research trial is happening in 150 hospitals in the UK and in more than 300 hospitals around the world. It is looking at which medicines will most help people when they're in a hospital for pneumonia, flu, or COVID-19. Research has already given us some information about what might help treat people who are in hospitals with lung infections, flu, or COVID-19. But we need to know more. especially as new medicines have become available. This research is called a platform trial. This means that several different medicines can be tested at the same time, and we can find out which ones work best and stop using the ones that aren't helping people with lung infections. New treatments can also be added. If you join this research, a computer will select one or more treatments for you. This is called randomization and means people are put in a group by chance, which allows us to compare different treatment groups. Are you ready to make treatment better for people with lung infections? Speak to a research nurse to find out more. If you agree to being part of this research, you'll be asked to sign a consent form and given a copy of it along with a privacy notice.
Okay, so that's the video we have. And then here we've just got the video consent process outlined. So the patient or the personal legal representative should be provided with the opportunity to watch the video, and then a nurse or clinician should provide the patient with the full PIS on paper, highlighting the interventions that are available and giving them the time required to consider this. And then they can ask questions, and then they should sign the video consent form. But it's just very important to note that they should still be given a paper copy of the full PIS and as well, in addition to this. So we are encouraging sites in general to play the video in waiting rooms, whether it's on staff iPads, or the link can be sent to patient relatives. Soon in the next amendment, I think we are planning on adding the QR code to the PIS so that patient relatives can just scan the QR code and the video will come up. Just going on to the antiviral swab guide. So in the flu strata, we do have swabs that are needed for the antiviral domain. So these are required on days 1, 3, and 7. We do provide all the equipment required for this, so we will send sort of like a package of swabs, tubes, and the barcode labels that goes with each time point to sites. I think we have safe boxes, but the labels currently need replacing. So I think some sites who might already have the safe boxes, we've got a new lab address, so we can send replacement labels for those. And then if you run out of or have any sort of expired bits, if you just let us know, we can send some more to you. We also have our sort of swab tracker, which is available on our website to download. And if we just remember to also fill in the details on the study database as well. So we now have electronic training logs, which should make things a bit easier in terms of staff training. It can be accessed on our website. And then once you sort of complete the log, you should receive an email, and we just ask for that email to be forwarded to us. This just allows us to identify that you are the person that has completed the training and someone else hasn't done it on your behalf. On Spinnaker, there are quite a few yellow banner alerts, and these should be resolvable. It depends what sort of actions you have at site that you might need to complete. If there's anything that you're not sure about, if you just let us know, we'll be able to help you out. I think if there have been any sort of erroneous alerts, we have tried to close them ourselves sort of first. Just a reminder of our website, we have separate pages for adults and pediatrics. We have our training materials on the websites, and then we also have the consent animation, the REMAP bites, our newsletters. We do have a document version tracker, which we try to update regularly, as well as our publications and FAQs. And then this video should also be on the website soon as well. In regards to funding, the study will continue to run this winter. We're just currently awaiting confirmation of details from the NIHI in terms of the extension. And then once we have this, we will submit to ethics and forward to sites as well. So I already mentioned that we will have Q&A sessions. These can be generic, or we may be focusing on certain things like consent or the database, depending on what sort of common queries we receive this season, and if there's any suggestions as well from site teams. So just a reminder of our email address for any questions, and the website as well, as it has a lot of information on it. We can always direct you to where our resources are as well. I think that's the last slide. Can't seem to click to the last one.
Thanks, Aisha. I realise we've got to 2 o'clock now. So just trying to address questions. Might come to you, Liz, about the day 180 follow-up. But Esther's asking a question about the consent process, that audio recording the PIS would be a helpful addition. Best will be able to see clearly. I think the answer is the last bit about using the video for this purpose. I think it would be, the idea was it was perhaps more user-friendly or to have than just a purely audio recording of the PIS, which again would change frequently. So I would suggest using the video consent that we have. That counts as the consent. You can always then pick out points on the PIS when I speak to relatives. That's what I do, sort of say, this is what this section covers. If they, for whatever reason, they are struggling to read all of it, take it in and explain the important parts and ask them what they want to know about. So that's how I'd approach that. The day 180 follow-up for the ward patients, that was what we were doing. We would, again, being part of a global trial, we were trying to get coherence around the world, so everybody do the same thing. Aisha or Liz, Lucy, I never heard the final answer about what the rest of the world was doing, so we want to align with the rest of the world. Do we have that answer yet about whether the day 180 follow-up is needed for the ward-based patients?
I'm not entirely sure, but I think it was just that all flu patients required day 180.
Yeah, I would say we'll get back to you on that. The reason, as I said, and this is it, we try to align everything around the world. And I know we were giving out that advice before because that was what we thought was happening, but then other sites have started doing it. So we will get back to you specifically on that point as quickly as possible. As I said, I realize we've got to 2 o'clock now, so we've come up for the end of the hour's presentation. Realize people want to drop off. Just say thank you very much for joining. As you heard, we'll be having regular updates now as we start getting into the winter, so you can ask more questions. We'll get back on the specific point just raised. Stay on for a couple of minutes. If people got burning questions you want to ask, please do stay on. But thank you all very much. Hopefully, I know it's tricky for multiple reasons, but hopefully, as you've alluded to, if we all do recruit a few patients, we will get the answers eventually. So please encourage your colleagues to consider randomizing patients. Thank you.
So I've just seen a question in the chat about if the patient is discharged before day 180, how do we follow up these patients? So most of these patients are actually followed up by telephone. So we just do the question, you would do the questionnaires, the WHODAS questionnaire and the EQ5D quality of life questionnaire over the phone with the patient.
Just to add to Aisha's point, we do have approval to send out the questionnaires to the patient via post or email as well, if the patient would prefer this.